Hello, everyone. Welcome to our summit on key considerations when incorporating SDOH data into payment models. My name is Matt Lambert. I'm the Chief Medical Officer for Curation Health, and I will be our moderator for today. Our platform will be some opening comments by myself, and then we will share about 5 minutes or so with each of our panelists, and then we will open it up for Q&A for our remaining time. My panelists today, our distinguished group that has joined us are Jennifer Frost with Kaiser Permanente and their Thrive Local program, Kimberly Harrison of Priority Health, Krista Hogland of the Security Health Plan, and Nicole Lowry of Humana. So I'll go ahead and kick it off with my comments, and then we'll hand it off to Kim first as we go down through our panelists. I guess I was selected to be the moderator for this panel based on a combination of experience. First thing is 20 years as an ER doctor led me firsthand to see how the social determinants of health can impact outcomes, access, and utilization. Secondly, as the Chief Medical Information Officer for New York City Health and Hospitals, the nation's largest public health system, learned firsthand how to manage a patient population, 50% of which was undocumented and uninsured. As the Chief Medical Officer for Socially Determined, we worked diligently in DC to incorporate SDOH into a sustainable part of healthcare delivery in the US. And then most recently, also wrote a piece that was picked up by some news outlets where, based on my observations thus far, SDOH investment is most likely going to lag a switch to value-based care. And that's a really good jumping off point into the discussion here. We have an industry that's finally realized that the effect that social determinants of health have on our overall health. And we're really kind of struggling on what to do about that. The Z codes exist, the ICD-10 codes exist to track social risk, whether it be food insecurity or whether it be transportation insecurity. And there are actually some initiatives to track that data and capture that data, but we're still trying to figure out how do we fit it into the particular model. And my thought is that this is most likely on concerns around volume of care. Any system in nature, the healthcare system in particular, is open to the law of entropy, which means that it's going to expand and grow more complex over time. And we can certainly see that US healthcare has done that. And there are really very few guardrails in that natural system on controlling costs and controlling services. So in a fee-for-service world, I am tied to the type of behavior that I have to do to get my operating revenue, which is ambulatory visits. Most commonly, the 99213 is the most common type of ambulatory visit. And that requires a very set of behavior that I have to do to get reimbursed. If we add additional reimbursement on top of that, let's say for food insecurity or for home delivery, we run the risk of adding more care just for the sake of adding more care. And we can, and I think the concerns are that can just become more expensive. In a value-based care world, that's flipped. Your primary way of revenue is a per member per month subscription model, where you receive your operating capital and are free from that fee-for-service behavior, and you can engage in patients in what might give them the best outcome and the best margin. So an example here is one patient might really do well with that traditional in-home visit. Another might do well with a text message. Another might do with a medication adherence push notification. Another might do well with a home visit. So once you're free from that sort of fee-for-service behavior, it allows you to provide direct SDOH investments in communities and in individuals, and do that in an individual way as opposed to an additive way. And the value-based care, the way it is aligned, it makes you it makes you track certain outcomes and certain interventions in a particular way. But that's not a subtle change, and that's a significant change, as a matter of fact. And lastly, before I hand it over to Kim, we'll talk a little bit about change in general. You know, there's been a lot of discussion around CRT, critical race theory, and there's been a lot of distortion around it as well. But I think there's one central principle here that really applies to what we're talking about, and actually, ironically, it has very little to do with race. And Derek Bell was the founder of that movement, and Derek Bell was a foot soldier in the civil rights movements of the 50s and 60s. Everything from Brown versus Board of Education all the way up to the LBJ's Great Society. And what he observed during that was that societies change, not when you change hearts and minds, but societies change when you get disparate groups in societies where their interests converge and it makes sense for them to make a change. Now, I think that pertains to any type of change in general, and certainly to healthcare change in particular. The only difference is I tend to use the term aligned incentives as opposed to interest convergence. So I'm going to challenge our panelists here when they're talking about their efforts at their organizations to describe to us how they are aligning incentives between payers, between communities, between providers, between patients, how they're aligning incentives to move forward with SDOH as a sustainable part of healthcare moving forward. Having said that, Kim, over to you.
Thank you, Dr. Lambert. I'm Kim Harrison. I am the Director of Provider Network Performance for the East Region of Priority Health in Michigan. I also have responsibility for our value-based payment programs. In my role, I regularly engage with our physician organizations and other healthcare providers on HEDIS performance, as well as other key initiatives that drive improved care, lower costs of care, and focus on the underlying drivers of our care and use. For a bit of background, Priority Health is the fastest growing health plan in Michigan, and we now serve over 1 million members. Our team is continually recognized as leaders in our community. We're very innovative, progressive in a lot of their programs. That's what drew me to Priority Health several years ago. And one area that we are an innovator in the state of Michigan is in our recognition of social determinants and consumption of Z codes. So starting just this year, January 1st, 2021, for our performance year, we instituted a new measure in our PCP incentive program for social determinants. The requirements for that are participating practices must be PCMH designated. We believe PCMH designated practices are positioned and organized in a manner to deliver organized care, as well as screen and gather information on social determinants to drive effective care. We expect them to submit Z codes to Priority Health on their claims, and we begin to gather this information. While we recognize the shortcomings of that, not all practices are able to do that for a variety of reasons. Either they are unable to impose on a regular basis in their workflow screening of patients consistently, translating what they're finding through that screening to a Z code, submitting Z codes through their EHR or another manner. So we understand the challenges of that for sure, but we knew that to sit and wait until we had a perfect solution did not support the provider community in starting the work, and I do mean starting the work of figuring out a way to uncover those underlying conditions that drive the effectiveness of care. So we started with this. What we have found to date is that based on a recent study out of the University of Chicago, where they found that 1.3% of Medicare beneficiaries had a social determinant submitted, we're finding that for our same population, we have received Z code submissions for Medicare members at a rate of 1.7%. So we see that the medical community is positioned to screen and submit that information. So we just require that they have a screening tool. We know that in our community, and probably in most communities across the country, the top social determinants that are usually uncovered are transportation issues, food security, and housing, as well as the ability to pay for prescription drugs. So we do require that any screening tool that is adopted at least uncover those. Now, we are only recognizing the screening and the submission of those Z codes right now. Through the gathering of this information, we expect to do some deep dives into what Z codes are we seeing, where we can, and we're going to look at it geographically too, because we know that the needs may be different geographically, and that could be because of the population or because of the resources available. Because we had a state innovation model in Michigan that ended in 2019, where many of our practices, particularly serving the Medicaid population, became very familiar with screening for social determinants, a lot of those practices just continued those efforts, working with community resources. So they had some foundation for not only screening, but recognizing the resources that could help fill those social determinants. So we will continue to do research on the data that we receive to see how we can support providers in the community. And that could be investment in the community. We understand broad-based internet is an issue. So if we can't engage a member because they have transportation issues and are unable to get to their provider practice, can we engage them in telemedicine if they don't have access to the resources that will gain them another means of engaging with their provider? So we're looking at what other opportunities there are in investing in resources that will help identify and close these gaps in care, because ultimately we will move our program from just incentivizing providers for screening and submitting Z codes to interventions, and then look at what the outcomes are their interventions. How long are they keeping those determinants addressed and closed? And what is the outcomes of that in terms of healthcare measures? So we have a long-term vision for this. We know we're just scratching the surface, but we took the plunge and decided to jump in and start. And as we actively engage with our provider community, we get the feedback. What are your hurdles? What are your challenges? How do you see us forming this program in future performance incentive years? Please provide us with those feedbacks, knowing that, as I indicated earlier, different geographies have different challenges and resources to meet these needs. Thank you.
Kimberly, thank you so much. Fantastic. Yeah, providers get hit with a lot of data now, and it's tough to really make sure that it's meaningful. And the other thing is, a lot of times providers still aren't trained on how to act on these. So it's one thing to identify them; it's another one to how do I act. So
absolutely,
fantastic start to your program, and fantastic start to our program. I think we have Nicole next on the run of show. Nicole, over to you.
Hi, Nicole Lowry. I am the Director of Population Health Strategy and Execution at Humana. I'm responsible for Humana's overarching social determinants of health strategy, how we integrate that strategy and our solutions within not only Humana's business, day-to-day operations, but also how we work with external partners and physicians to really make sure we are providing whole person health. So one of the things I wanted to talk about is a little bit about Humana's bold goal. So in 2015, Humana embarked on what was a little bit of a new frontier for healthcare, and that was really diving deep into a community to understand the barriers that exist for a patient or our member or someone within the community to access the care that they need. We started this with Project San Antonio, and over the last several years, we in 2020 expanded to 16 communities, and I'm really excited to say that this year we are moving to 18 by the end of the year. And so we're really looking at how do we improve the and better serve not only our members, but the members of the within the community to make it easier for everyone to achieve their best health. In 2020, we did screen for 3.5 million for SDOH, or sorry, not members. We screened for 3.5 million SDOH needs. And we were able to give back 816,000 more healthy days for our Medicare Advantage members in 2019. We're still disseminating some of our other data. One of the things we also have done, which I think is really innovative, is that we've launched some strategic academic partnerships to really start training the physicians of tomorrow. So one of the things we've heard, and we'll get into some of our physician facing programs in a second, but one of the things we've heard over the last several years is we're really working with physicians to really push addressing health-related social needs, is that there's really not a great place to start. We know that today in some of the EHRs, and that's only in some of them, that there are modules already built to screen. But what happens when someone screens positive for a health-related social need? How are we going to address it? How are we going to make it easy? And then let's also not forget that addressing a health-related social need is not considered a primary health diagnosis. And so it's not reimbursable today by CMS, as Dr. Lambert mentioned and Kimberly touched upon. So how do we start gathering this information? How do we start making the case? How do we join our partners and health plans across the country to really start working with CMS and CMMI to change the designation? One of the other things, and I think everyone on this panel is familiar, COVID threw a smith health spin. From Humana's standpoint, members started calling us and not really worried about anymore about whether their prior auth was going to get approved for their surgery or whether or not the doctor they wanted to go see was in network. We were getting, by April 15th, guys, we were getting phone calls from our members saying, I don't have food. I can't take my medication because I don't have food. I'm being told to shelter in place. For example, even if financial funds were there, Instacart, things of that nature, had a 2 to 3 week waiting list if you could even get on the platform to schedule groceries to be delivered. And so we have delivered over 1.1 million meals from March 2020 through the end of, it'll be a little bit over that, through the end of this year in response to COVID-19 for our members. And that is a direct result from the great partnerships we have created within the community. And just really, I think it speaks heavily to our investment and our belief in that health-related social needs should be a primary health diagnosis and should be treated just the same. If you will go ahead and move to the next slide. So one of the ways that we are doing this today is we have really made a major investment in our data ecosystem and how we think and show up with this information, both internal and external. And so the first step is we have acquired a lot of data, maybe sometimes in too much data or not the right data, but we have claims, we have information from providers through our networks. We have information through our clinical programs, through pharmacy, wellness, devices, you name it, we have data on our members from the community. So whether it's something such as the local court systems, where we find out that our members are going up for eviction, whether it's social determinants of health data sets we purchase externally, or any other public-facing information. We also, when we mentioned those 3.5 million screenings, we ingest all of that information on our members. We mine through national language processing and structured text. So for example, if a member calls in through customer service and customer service isn't going to screen the member, maybe it's just not part of the script for that member for that day, it's not popping up. If customer service puts some information into the comment section, we go and mine that data to try to really understand every piece of information we have on that member. We've worked through data governance processes, business roles, and really have built some strong analytics tools and predictive models for our members, so we can then surface that information at the right point in time. And while that's really important internally, I think it's more important external as we start talking about moving the needle across the board. And so we're working on integration with EHRs. So at that point of time, at that point of influence, when the member screens positive for a social need, we are working to say, okay, yes, Jane Doe has a transportation barrier, which we know that 10% of our Medicare members today do have a transportation barrier. Around 30 to 35% of our Medicaid members have a transportation barrier. So when that barrier comes up, we are going to be able to surface things such as what type of transportation benefit does this member have? What local resources are available, and really allow the person who's doing the screening or has the patient in front of them make really informed decisions at that point of influence. Really make that connection, because let's be honest, today that connection is not easy. Kimberly, you mentioned how hard it is today for physicians to find the time, create the capacity within their workflow, and connect to systems sometimes that are super expensive. They're really not affordable. And because these addressing social determinants of health is not currently reimbursable across the board, it makes it extremely difficult. And so for us, we're really working to operationalize this data. So we are building pilots and interventions based on really informed decisions, informed information. Working to get to that operational maturity across the board, both internal and external, and then how can we make recommendations? I mentioned the EHRs. And so the business impact. We're using data to identify needs, gaps, and opportunities, drive an improved experience for both, honestly, both our members and the physicians and clinicians that we work with, and really driving to the measures that prove the value of engagement. If you don't mind moving to the next slide. So one of the things I'm really excited to talk about, and this is really with a couple of my coworkers, this is our baby. We do have a SDOH value-based payment model today. We started this payment model in April of 2020. Timing was not ideal, right? But we did start this payment model with 7 physician groups across the country. We're still in the pilot phase, but we strategically partnered with physician groups within our BOGO communities. I mentioned those earlier. We started in 2015 with San Antonio. At the end of this year, we're up to 18 communities. It had to be a provider who already had a downside risk value-based relationship with us. So already we're used to managing the population really well, highly engaged, and then willing to publish findings with us. That's really important. If we want to get to SDOH being recognized as a primary health according to CMS, we need to be able to publish. And so we did. We found seven groups across the country. And what we are doing is when we've identified populations for each of the groups, and we are expecting these groups to screen the members for health-related social needs, to code using those Z codes. They also have to connect to the resource. And so say a member is food insecure. So we're expecting the Z code to be provided within the claim or in the shadow file, because we know a lot of times Z codes fall off of those claims because of limitations. We expect that the physician group is providing a resource, whether that's a food pantry or something of that nature within the community. Following up, the physician group has to follow up with the member to make sure that they go. And if they don't go, why? How can we still get that member to the resource that they need? Removing all the barriers that we can. And once we have all that, once all 3 of those steps occur, we do provide an incentive per member for the physician. And lastly, we're really looking at measuring those outcomes. And those outcomes are a couple things. First, is the physician group using this methodology? Are they following through? If they're not, why? Is the incentive that we have set forth for these physician groups, is it enough? You know, think about the days that we started value-based payments. Originally, we invested very heavily in the physician groups in order to be able to be very much MER-driven versus fee-for-service. And so we're really studying to make sure that the incentive aligns with the ask. Do we see for these members the MER dropping to the point that we expect it to drop, so that these downside risk providers are really seeing the outcomes that they expect? And so we're still, I would like to say we're ready to publish. We're not. We have a lot of bumps in the road, very transparently, especially with COVID. A lot of resources were diverted from these groups to deal with COVID response. Systems weren't updated as quickly as we expected. And so we're still in the, we're still have our sleeves rolled up and are in the nitty gritty of this pilot. But we're really excited about the possibilities here. And we think it's just a great example of great care being delivered through care coordination. And we're excited to see where this goes.
Fantastic, Nicole. Thank you so much. I love this visual here. It really describes the alignment of incentives, everything that has to come together to do this in a sustainable operating way, and especially connecting and acting on this and measuring the outcomes. Fantastic stuff. We're going to go to Krista here in just a moment. We have some great questions collecting in the chat. So Janice, especially, thank you for adding those. We'll save some time at the end to address those. And then without any further ado, we'll hand it over. Krista.
All right, thank you. So I'm just going to start by telling everyone a little bit about Security Health Plan. It's a not-for-profit insurance company based in rural Wisconsin, and that's really important. You'll see why on the map on the next slide. We have about 215,000 members and about 500 employees. We are part of a larger integrated health system, which is an important piece, I think, of our success, especially when we talk about the space around social determinants of health. Having that integrated provider system, having the clinic, the hospitals, as well as we have a research arm that can all kind of be thinking about this in the same way collectively. And then, of course, our mission, vision, and values, which I've shown here, become really important. This guides everything we do, and it's, again, particularly important when we talk about population health and social determinants of health, because sometimes we need to do things not because of the ROI, right? Not because they're going to return a financial gain, but because it's the right thing for our communities. And that's really highlighted here when we talk about our mission, especially. And, not everything has to be about margin. Some things are about mission. So if we want to go to the next slide, I think this helps highlight why it's really, really important to us in particular. So we've got some maps on the next slide. Are we frozen? Oh, there we go. Okay. So the map on the left shows our Security Health Plan service area. So all of that orange is covered by us as an insurer. But the red outlined area is our core service area. So that's where we have the majority of our members, and it's also where we significantly overlap with our provider system. The map on the right is an area deprivation index map. So this is developed by researchers at the University of Wisconsin in Madison. So many people may already be familiar with this type of a view. And it maps out areas of high need. So it takes census information around income, education, and employment, and kind of plots that out on a visual map here. So you see, by the concentration of orange and red in particular in the service area that, we do serve some fairly disadvantaged areas. Our population is older, sicker, and poorer, as we kind of highlighted on the top. And so, for example, the average annual income in our service area is $40,000 for a family of four. And in a third of our counties, there are fewer than 2 workers per Medicare beneficiary. So again, kind of a significantly older and sicker population. So with that background, I'll talk a little bit more about some of the examples of how we're using data to help to address social determinants of health. So the first example is something that our data analytics team has done. So very data heavy, not yet to implementation yet, but we're taking member level information, particularly around gaps in care, but other clinical information. And then we're starting to layer in some of the publicly available information like what we're showing here, but also county level risk information that layers in that social determinants of health risk. So it's imperfect, right? Because you've got individual medical data and you've got county level risk data, but it starts to paint a picture of why something might be happening clinically. So for example, if somebody's got a lot of gaps in care because they're not showing for appointments, and you can see from the county level risk data that transportation is an issue, you can start to figure out how to address that, as opposed to just calling repeatedly to schedule appointments. That's not going to be helpful. Perhaps there's another route that's going to be more successful in actually getting the person the care they need. Another example that I think is really powerful is something from our entire health system. So again, it's the plan side and the provider side working together. We've partnered with NowPow, and this is a platform that helps us with screening social determinants of health, and then also helps us to connect people to community organizations that can close. So we see this as very dual purpose, right? First of all, it helps us gather the data, understand our population, understand their needs, but then we can leverage existing partnerships with those community organizations that are already in place. And rather than handing them a card and say, call this person, we can actually make the handoff for them and make it easy and accessible for them to actually get those needs addressed. And then the final example is we've got a food pharmacy pilot, again, from a system perspective that we have. So we use data to determine that this food pharmacy was a potential need in one of our communities. And then we're continuing to use data to find that right population. So we wanted diabetic patients. We wanted them to be on Medicaid. We wanted them to be on controlled A1C and also screen for that food insecurity. So lots of data to kind of help us zero in on the right population. And then, not just providing them with food, but behavioral coaching. And then the food kits, not just for the individual, but for their entire family. And then cooking classes and cooking supply support. So, kind of a huge full gamut, just not just, again, providing them food, but providing them education and support so that they can, continue that right care on their own. So right now we have about 50 participants in the program and starting to get that outcome data that's going to be so powerful for expanding a pilot program like this, showing improvement in the biometrics, but also seeing, the confidence and the behavior change in the individuals that are participating in the program. So just one final thing on the next slide. One more slide. There we go. So this again is a really kind of practical application of using a product, using a benefit structure through Medicare Advantage. And I know we're not unique. Many organizations do this to say we're going to cover things above and beyond typical benefits that start to get into that social determinant of health space that can really help address members' needs beyond the direct sort of medical things. So, I'm not going to go through every piece, a few examples. I think people sometimes, shake their heads at that glasses and hearing aids, but you think about the social isolation that somebody will experience if they can't see or hear. Over-the-counter meds really, or other products can really be a helpful sort of cost savings, something that someone can't afford, but can actually keep them healthier. And then finally, under staying healthy, we recently launched a meal program, so similar to what others have shared, but for those discharged from the hospital. So knowing as someone goes home, they're already kind of vulnerable, they may not have a support system, we provide those healthy meals for them to kind of get them through the first few weeks at home so that they can be healthy in their transition, reduce their risk of a readmit and ongoing health issues, simply by providing that little bit of additional support as they transition home. So Matt, I'll turn it back to you.
Thank you so much, Krista. It's interesting. We got 30 minutes in before somebody mentioned, NowPal or Aunt Bertha or Unite Us or something like that, because they've been so prevalent in the space. And one of the things that I've learned from working with them was just the maintenance that it requires to, or just the challenges that the community benefit organizations are under, right? They're very often underfunded, they're understaffed, often charity, and just so they could serve to, as we can converge interests here, getting more resources to those community benefit organizations is going to be another upside to really managing SDOH very well. So thank you so much for that, Krista. Jen, over to you.
Great. Hi, everybody. I'm Jen Frost. I am the National Director for Kaiser Permanente's Thrive Local program. Thrive Local is a pinnacle piece of Kaiser Permanente's social health practice, which aims to address upstream drivers of health by systematically screening for and addressing patient social needs. Now, I mean, since this conversation, is really kind of rooted in reimbursement and payment models, of course, Kaiser Permanente is both a payer and a provider. And as a prepaid health system, we are not looking at SDOH from a reimbursement lens so much as from a quality and equity lens. And we are deep in the work of integrating screening for and addressing patient social factors as part of our care delivery system. We've all known for years that social factors have a disproportionate impact on health and well-being. And we've begun to build an enterprise strategy to elevate social health to the same level as physical and mental health. And in doing so, are really driving toward transforming how we think about and deliver care. And the framework for this is really built on the end-to-end workflow that I've heard a lot of my colleagues here talk about, right? Identify where there's social needs, connect where people screen positive, and integrate some support and follow-up so that it is part of an end-to-end workflow. Now, Thrive Local really fits in that middle section around connection, right? It is our enterprise program to connect our members to community-based resources to address those social needs as part of our care delivery model. And at its core, Thrive Local is a technology platform that our patient-facing teams can leverage to send and manage electronic closed-loop social referrals. And it enables a broader collaboration among health plans, care delivery, and our community-based organizations in our communities so that we're working together to jointly serve our shared populations. Thrive Local is fundamentally about equity because what we are endeavoring to do is eliminate socioeconomic and systemic barriers that prevent people from optimal health. Now, we launched Thrive Local in 2019 through our partnership, I'm going to use the word, with Unite Us. So you waited to me to get there. So, we're working with Unite Us to create these collaborative networks of community-based organizations and other healthcare providers in all of our service areas across the United States to serve our 12.5 million members. And to your point just now, Matt, there is a lot of work on the CBO side, and Kaiser Permanente does have a funding arm. As a true nonprofit, we also have grant-making capability, and that is part of our strategy as well, is to simultaneously support the CBOs with strategic funding as well. And truthfully, we're building community networks, not just for KP, but with our communities as an asset for our communities as well. So we're 2 years into our implementation timeline, and we expect the initial phases of that work to be complete next year. And that implementation is really standing up and turning on the lights for these community networks and recruiting our organizations to join us. And once you turn on the lights to a network, it is not a drop the mic moment, right? It is a continual process to engage and recruit and grow these networks, to optimize them, to learn from how people are using them. What are the needs that are surfacing? What are the CBOs using them for? And how do we continue to grow and invest in these networks? Now, we are still early in our journey. With regards to utilization of the platform by Kaiser Permanente's care delivery teams, we're definitely in the early stages of what our long-term goal is, where we have full penetration of screening for and connecting to address social needs throughout the fabric of our care delivery and patient services infrastructure. While we are rolling out Thrive Local to our care teams, we also added an online community resource directory to our website, kp.org, and we did that this past summer. And then last year in May of 2020, as part of our response to COVID-19 and the pandemic, we accelerated the opening of a dedicated social needs call center And the call center agents are trained to use our Thrive Local Unite Us assets as well to support the members who call in to screen them for social needs and help make connections to services as they're able in our communities. At the end of the day, I know we all believe that integrating these elements into the overall care experience will contribute to improved equity and quality outcomes. And before I close, I just want to make a note. I heard somebody earlier talk a little bit about training, right? This is new for many care delivery teams, right? The medical model has been the medical model for many years, and this is an expansion of that concept. I think that means that we have to expect some enhanced training of our patient-facing colleagues across this industry to understand better how to talk about some of these things, to make thinking about social needs as common as taking a blood pressure, but to be able to do that with respect and thoughtfulness, humility, that is really needed to have those kinds of conversations. And so that is also something in other elements of our work that we're working through thinking about how to do as we really transform how Kaiser Permanente designs and delivers its services. So I'll pass it back to you, Matt.
Jen, thank you so much. Yeah, it's interesting, the training piece, right? I think, at least in my experience of talking to folks around the country, some of the big academics are the last to move into this space right now, just because of how their incentives are set up. But the pressure's on for Kaiser, because not only have they had, they've had more aligned incentives than others since, going back to probably the 70s, right? And also, not only that, it was my first job as a night shift ER doctor in Kaiser, San Diego. So pressure's on with that. Okay, let's see. We've got 20 minutes or so remaining. We've got 9 questions in the chat. I'm going to go ahead and just open the chat up and read these to the group. And we're going to rely on my panel to help me out here. So Janice, thank you so much for your questions in the chat. For those of you who can't see it, Janice is and Jennifer Powell have sent a lot, but Janice has sent several. So the first question from Janice is, do you see efforts to bring community service organizations onto FHIR to use the same data and exchange formats, requirements, etc.? Any of the panelists have a take on that? I have one. If we don't, I can take the first one since I'm the tech guy, I guess. Yeah, I think we mentioned about CBOs. CBOs don't have this talent, don't have this money, and that's where the Unite Us, the Now Pals, the Aunt Berthas have come in to provide these services for them, and are certainly connecting to a lot of different EHRs and a lot of different data centers in different ways. One of the unintended consequences of the way we did meaningful use was we made a lot of silos there for sure that we're having to work through to talk about exchanging information on that. So great question on that, Janice. Anything to add to that? Oh, wait a second. I'm getting from Sarah Bryan. I got another message here. Just 1 second. I'm sorry. Okay. 3:50-ish is when we have to shut it down. So we'll move. We've got about 10 minutes left or under that, so we're going to go a little bit quicker. All right. Next question from Janice. Do you have any sense of what percentage of SDOH needs of Medicare populations are being missed because of lack of reporting, difficulties, capturing codes, etc.? Team, what are your thoughts on what percentage we're capturing and what percentage we're missing associated with that?
So since Medicare members are about 50% of our total members, and we're only screening so far across all of our membership who have had an office visit so far this year, 1.7%, we know we're missing a fair amount of those. We're still overcoming the hurdles of COVID and engaging those members. So we are working very closely with our physician organizations to find out independently what their hurdles are. Our incentive is for our Medicare and Medicaid populations. We think those are the most vulnerable and experiencing probably the majority of social determinants in our membership. So we continue to find ways to help, with integrate screening more robustly. We work with our Michigan Health Information Network too, that has a use case for that. So they work also with our physician organizations to find out how to gather that information, because some of it might just be reporting. They could be screening, they could be intervening. They don't have the capability of support reporting Z codes. So I know that we're getting that underreported. However, those needs are still being met to some degree in the community.
Yeah.
And just if you don't mind, if I'm building on what Kimberly was just saying, 2 quick things from the Kaiser Permanente perspective. First, we did the social needs survey in 2020, which, as it happened, started before COVID and then lasted through COVID. So we got to see the pre and post there. And we believe that 3 in 5 of our membership have at least one social factor that they need help with. So the opportunity is large. And then I think to Kimberly's point, how often you screen and identify us, the first step in this workflow. And, we have a goal of, in the next 2 to 3 years, getting to the point where we are screening every year, 70% of our membership annually for social needs. So just kind of wanted to share that context.
Yeah, thank you, Jen. Thank you, Jen. Very good. Next question, again from Janice, and she's talking about what a theme here. It's one thing to capture, but it's another to act, right? That's a challenge for everyone, not just us on the panel here. And are there different where you might capture any of the underlying causes for there? And I'll go ahead and answer that just in the interest of time. I think right now it's enough to capture the presence of risk, and then maybe ongoing through care navigation or care managers or that long-term relationship from a care team. You might be able to get to more, and that's also kind of the value of home visits. I think you might get that extra want to, but I think we're still just capturing right now the presence or absence of. And that segues really into Janice, into Janice's next question. And I haven't been as close to this as I once was, so I'm going to rely on the team here to help me out. Screening tools. I know there was a lot of discussion getting a common language around this and a drive towards common screening tools. What screening tools are the panel members using to screen for SDOH risk?
I'll start and take that one. I'm sure everybody has their own. We do rely on the accountable health communities quite a bit for the screening that we do that goes out to our membership. When we're working, and then we also use UCLA3 quite a bit as well. One of the things I will say is when we're working with physician groups and CBOs and outside entities, we provide a whole gamut of surveys that are validated, and we really let the organizations decide which ones they're going to use.
Yeah, we made several suggestions to the provider community who want to participate in this measure of those tools that we heard back from the community we're actively using already, setting a minimum of screening for those 4 social determinants that I mentioned earlier on: transportation, food security, housing, and ability to afford medications.
Fantastic. And just another question or sub question there. Is anyone using AI to do this, or any assistive technologies to help with this, or is it still?
We use predictive models. So the data that we gather internal, that we have on the member, whether that's claims, pharmacy, free text, we do use that to help determine whether or not we feel a member is at risk for a social need. And that does tie into, I believe, the ability overall to negate some of the concerns that we're missing members' social needs. And it's not perfect. I mean, nothing with AI or data analytics is perfect, but I do think it's a step in the right direction.
And Nicole, you've got another question here directed to you, but before we get there, who does the screening? The patients fill them out, or the screening tool themselves? I think I've seen every iteration of this. Sometimes a care manager, sometimes an MA, sometimes if the patient's facile enough, they can do self-reported risk as well.
And we're rolling out digital self-screening tools as well for KP to try to get as broader reach of our membership as we can.
All right, fantastic, fantastic. And then we've got a minute left. Pressure's on, Nicole. This is from the Healthcare Strategy Bullpen. Can you tell us about incentives and how they are determined? Actually, it looks like you're responding to that, or we're within.
Why don't you let me respond to it and move on to the next question? That way we get another one.
Perfect. Okay, who does the patient screening? We got that one. And then let's see, Janice. A comment and a question as much here. Paid out, let's see, from lump sum value-based care payments to providers, paid from providers reserve, very limited fee for service options. Do folks see other models? What do we think works best? Wow, yeah, we could talk for another 50 minutes on that one, right? I opened it with saying that I thought adoption of social determinants of health makes the most business sense wrapped into VBC. And I will close our session saying I still think that is the most, at least that makes the most sense to me. Now, a lot of things about our healthcare system don't necessarily aren't as logical as we would like them to be always. But Janice, I think that seems to be the most sustainable path to wrapping this in. And speaking of wrapping it up, we're going to go ahead and wrap it up now. So I'd like to thank our panelists. Thank you so much. It was fantastic. Thank you for bailing me out when I didn't know any answers. And thank you for those who joined for their insightful questions. And thank you for the folks at eHI for hosting this event. It's been a real pleasure. Thank you all.
Thank you.